Thank you all for returning. If this is a return visit, and if it's your first time, welcome to the monthly Healer webinar. Usually these webinars are reserved for members of the Healer certified training community, but since the COVID crisis and everybody's spending a lot more time at home and needing information and wanting to learn, we've decided to give access to the general public. And I'm very happy to do that tonight. So thank you for joining. We would love for you to join our Healer certified community. We have a really comprehensive yet concise curriculum about cannabis. We have recordings of all the previous webinars and many resources. And so if you're interested in becoming more of an expert in taking care of yourself or taking care of others, whether you're a caregiver or a clinician or anything in between in the cannabis industry, we would love to have you join us. It's a great community and a great program. The other thing that's a little new is that lately I've been having guests on the webinar to help me do what I do. And I'm just so honored and excited to have great guests over the last couple months. And another one tonight, Dr. Patricia Frye, who I've known for several years. She is a physician consultant whose practice, located in the Maryland suburbs of Washington, D.C., focuses on cannabinoid medicine and the role it plays in pain, in treatment of chronic pain and chronic other disorders. She's professionally certified in cannabis science and medicine by the University of Vermont School of Medicine, has evaluated and managed more than 5,000 patients on the use of cannabis for a wide range of conditions. And she has a specialty background in pediatrics. The reason that I invited Dr. Frye on tonight is because she's an extremely dedicated clinician. First of all, I know how much she cares about the work she's doing. She's doing it out of the love and joy from her heart. And I think whenever anyone's in any job or any profession that has that kind of dedication and enthusiasm, they're likely to learn a lot and to be able to share a lot. She also has a background in integrative medicine. She is very comfortable going to the primary literature, and she's very creative in the clinic and finding creative solutions to some of the really tough cases. And so as I share with you all my clinical experience, I feel like it's really helpful to have another clinician that's been in a similar role yet in a different setting, so that we can see what are the similarities in our approaches to some of these conditions and cases, and what are the differences and what we can learn from all of that. So thank you, Patricia, so much for joining us tonight.
Thank you for inviting me, Dustin. Happy to be here.
So the way that we usually run these, and tonight will be the same, is that we start off with a slideshow presentation of the research articles that have come out in the last month that I think are either interesting or clinically relevant. And so we're going to go through a slideshow, which I'll start very soon. And then we're going to use each of these topics as kind of a jumping point in a conversation between Patricia and I to talk about how we approach these conditions and also what we think about the meaning of these articles and the implication of these articles. We love to have your questions and comments. So if you'd like to submit a question, you can do that on the chat. It's always fun to have live questions. So just message to Simone Foyer, and she'll put you in the queue for asking a live question after we're done with the slideshow. And I think those are all of my announcements. So let's dig into the research that we have tonight. Oh, and you know what, Simone, it says that I can't share because someone else is sharing their screen. I'm not sure who that someone else is. Oh, it's Barbara Shea. I'm not sure.
Yeah, I'll take care of it. Give me 1 second.
Okay, thanks. Okay, that's probably good now. Let's see. Yes, thank you. So now I just need to find the PowerPoint. Very good. We have a number of topics tonight, including short and long-term effects of cannabis on PTSD, CBD and CBDA, for nausea. I know a lot of you that have been following my work know I'm very interested in the acidic cannabinoids, and so here's a little preclinical research on that. CBD extract and HDL cholesterol levels, cannabis use and the risk of stroke, cannabis and irritable bowel syndrome, cannabis and migraine headache, and then the ancient spiritual use of cannabis. And I think each of these will be a really good opportunity to discuss some very prevalent and common conditions. So, and Patricia, please interrupt me, chime in at any point. As much as you have to contribute, that's as much as I want. So this first study here is on short and long-term effects of cannabis on symptoms of post-traumatic stress disorder. And this was generated from anonymous data collected from an app called StrainPrint. Users would self-report as having PTSD, so we don't really know that they have that diagnosis. And then they would use the app to track their symptoms before and after using cannabis. For this particular study, they had 404 people who said they had PTSD, who recorded their cannabis use sessions over 11,000 times in total over 31 months. And they selected for only the people that were inhaling cannabis, and for the sessions where they re-rated their symptoms within 4 hours after inhaling cannabis. So that makes it more of kind of a standardized data set. And here we're going to just jump straight to the results. So again, this is very observational data. This isn't a randomized controlled trial, which, by the way, I didn't include it in the report tonight, but this paper did include some previews of 2 randomized controlled trials for PTSD that are going to come out soon, but we will cover those once they're published. But there was a couple sentences that describe their results. But anyways, these are some of the results from this study. So first of all, how many sessions did, among all the sessions that they recorded, how many of them resulted in an improvement in symptoms? And the numbers are really high. So almost 98% of the sessions where someone was having an intrusion, which would be like a thought or a memory or a feeling related to a past trauma, just intruding into their current, present moment. Almost 98% of the sessions improved that symptom. Almost 92% improved flashbacks, 97% improved irritability, and 93% improvement in anxiety. So this is a very high response rate. This tells me that out of these 404 people, almost every time they inhaled cannabis, they experienced some improvement in their symptoms, and very rarely did they experience a worsening of their symptoms. So you could see for some people, about 3% of the time, flashbacks got worse after using cannabis, anxiety got worse, and that's certainly possible. We know that cannabis is a double-edged sword. It has these bidirectional effects. So if it can help with a symptom at the right dose or the right type of cannabis, it can probably make the symptom worse at the wrong dose and the wrong type of cannabis. And that's true most of the time. So this was very promising data. And then if we look at how strong was that improvement? So that last slide just showed how often were they getting some improvement. But now this is the average amount of improvement. So they rated, for example, the intrusions on a scale from 1 to 10, say average around 7 before cannabis, after cannabis average around less than 3. So that's a really pronounced improvement. Same with flashbacks, same with irritability, same with anxiety. A few differences in genders. Women reported a greater percentage of sessions in which flashback severity was reduced, more than men, so that was statistically significant. Men reported significantly more sessions involving reductions in irritability, and women reported more sessions in which anxiety was reduced. So what does this mean? I'm not sure. I think it's always nice to look at gender differences because in my practice, I've observed that there are some ways in which cannabis affects men and women differently. And so this may mean that men are more likely to respond for irritability and women more for flashbacks or anxiety, but it may not mean that at all. That might just be an artifact of this data. And so in conclusions, 62% reduction in severity of intrusive thoughts, 51 in flashbacks, 67 in irritability, and 57% reduction in anxiety. With significant heterogeneity across individuals. So some people responded really well, some people didn't respond that well. But this indicates that cannabis may not uniformly reduce PTSD symptoms for everyone. Now, a lot of you are probably thinking, well, the study doesn't really tell us anything that we didn't already know. Cannabis is good for treating PTSD symptoms. That's a very common reason people use cannabis, and inhaled cannabis can reduce symptoms very quickly. That's also something we know. Maybe nothing new, but certainly confirming that information. And I'd just love to hear your comments, Patricia, on the use of cannabis for PTSD, any clinical pearls you have, and then also your thoughts about inhalation versus other routes.
Yeah, those were my thoughts, is that this was all inhalation. It was probably all THC dominant. I see a fair amount of PTSD. A lot of it's military related. And then there are other, of course, there are other causes besides being in a combat zone that causes PTSD. I see patients that have had, really debilitating chronic illnesses or have had tragedies in their families. And while I think inhalation and with THC at small doses can be very helpful for mitigating some of these acute exacerbations of their symptoms, most of my patients I have convinced to use a THC CBD tincture kind of in the background, because we still have stress as a part of post-traumatic stress, and we have stuck circuitry. And the CBD can actually, by interfering with the FAW enzyme, increase anandamide and help to get the amygdala, which is the area of the brain that gets the signaling that we have to be vigilant and ready to take on some survival techniques. It helps to tone that amygdala so that it stops signaling to the hypothalamus to continue this stuck circuitry of being ready to fight or flee. So I like using a little CBD on a daily basis, and then I ask the patients to use their vaping or their smoking as sort of their extra medicine, as opposed to using, depending on it, completely. And the other reason is that with the inhalation, it just doesn't last long enough to really get up under a chronic problem. So that patient will constantly be chasing their symptoms. So I like an oral mucosal absorption as well.
Thank you. Yeah, I agree. I think there's treating acute symptoms, which is extremely useful, and I think, the times in which that might have a long-term benefit for the patient is when they get this perspective. They see like, wow, I was so anxious and in such a state 5 minutes ago, and now I'm feeling so much better. And just having that, looking back and seeing that rapid shift, sometimes they can learn something from that, and that lesson may last for days, weeks, months, way beyond the acute effects of the cannabis. But in general, I think, and a lot of you that are in the healer curriculum, I like to prevent symptoms more than chase them around, even though both techniques are very useful. And certainly an oral dose of combined CBD THC is something I recommend often in my clinic as well. There's so many people with PTSD that have gotten great results inhaling and are almost satisfied with those results, but they haven't really changed the core of their condition. And we'd like to change that and help them no longer have PTSD. And for those of you that tuned in last month, we covered an MRI study that showed that with oral dosing of THC, there was better connection between the frontal part of the brain, where we can say to ourselves, hey, I'm not in a threatening situation, I shouldn't be anxious right now. And then that limbic part of the brain that actually gets anxious, that connection is often disrupted in people with PTSD. And it was shown in this fMRI study that under the influence of oral THC, people were better able to make that connection and to mitigate their anxiety in the so-called top-down manner. So I think taking it orally is a great approach. The strain print data is very interesting. I think it's, if we can get more people who are using cannabis to record their sessions, and especially if we can have a better understanding of what they're using, what's in it, and what the dosage is, I think we could learn a lot from strain print. So far, the findings are pretty preliminary, as you can see in this study. Not earth-shaking news, confirming what we're seeing in the clinic, but for those of you that are interested in contributing your experience to a greater pool of data from which more studies can come out, you could check out strain print.
I also wonder, Dustin, about the motivation of people who are not responding, and are they, inputting as much as the people who are getting good results? So we may be seeing some skewed.
For sure. I think there's some selection bias there, right? Strain print's not going to capture who's the people that aren't responding. I think it's unlikely. Oh, well, they captured some, but
Mhm.
not nearly as many as the people that are really enthusiastic about their good results. I want to put this in the app. So I guess if you're getting bad results with cannabis, please send it to Strain Print and to us. Okay. Oh yeah, a couple more conclusions. Those with more severe symptoms reported greater reductions in their symptoms after cannabis use. That may be because cannabis is more effective for more severe symptoms, which is often the case. Cannabis tends to have a more pronounced effect when things are more out of balance. Alternatively, that finding could simply reflect the fact that there's more room for improvement when there's worse symptoms. And then they did not find any correlation with the amount of THC or CBD on the response rate. And that's something that I think Strain Print's been looking for a long time, and all of their studies published. I'm not sure about that, but I think all the studies that have come out of this data have not indicated, wow, this particular type of cannabis is better for this condition than others, but they're going to keep looking for that, I'm sure. And then, oh, this was an interesting one. The results improved over time for intrusions and irritability, which may indicate that cannabis becomes more effective the longer someone uses it. Or again, this could be a statistical artifact that those who obtain the greatest relief in the short run are more likely to continue using it for a longer period of time, and that's why it shows up in that data. But I suspect it's the first bullet point. I think that cannabis has a pro-neuroplastic effect. It can help people, it can assist in their capacity to change their patterns of thought and behavior. And, you know, I see people over time, the longer they use it, the better results they get. But what do you think about that, Patricia, as far as cumulative benefits or benefits improving over time?
I do see that because oftentimes if I start patients, I will have them use cannabis as much, as often as needed or it could be once a day, twice a day, 3 times a day on a daily basis for a couple of months. But generally, once they've used it mostly daily for 2 or 3 months, they can often go to maybe 2 or 3 times a week. So that daily dosing doesn't really seem to be necessary over time.
Great. Okay. There's more conclusions on this one. You can see I put a lot in here. Consistent doses achieve larger reductions in intrusion. Oh no, let's skip that. We don't need that. But this was an interesting one. In the conclusions, they said, results from the present study indicate that acute cannabis intoxication provides temporary relief from intrusions, flashbacks, irritability, and anxiety involved in individuals self-identifying as having PTSD. And I saw the word intoxication, and I thought, what is that talking about? So I emailed Carrie Cutler, the final author of the paper, someone that I know and that I've met from ICRS. She's out in Washington State and has done a number of these observational studies, and she apologized for that language. She said it was an oversight on her part. They did not include any measures of intoxication. And as far as she knows, these individuals were not intoxicated. They were just under the acute effects of cannabis. So consider it a typo. Okay, moving on, CBDA. So now we're going from something very relevant, PTSD in humans, to something that you may think is not very relevant, CBDA in rats and shrews. A shrew is a rodent that has the capacity to vomit. Rats don't vomit, they just gag. And so different ways of measuring nausea and vomiting in rodents. But the reason I include this is because I've been so keenly interested in the acidic cannabinoids, especially interested in their ultra low dose range. I think something special is happening there. We don't have a lot of explanation for it, but this particular group, under the supervision of Linda Parker and often spearheaded by Aaron Rock, they absolutely understand this ultra low dose range of the acidic cannabinoids, and they've been actively researching that. And so whenever they publish something, I always cover it. So the thing that was a little bit different about this study is that in their previous rodent studies, they were injecting the CBDA or the THCA or whatever else they were using into the abdominal cavity of the rodent. But this time they were administering it just under the skin, which would be, you know, probably when this ends up translating to people, it's going to be just fine to take it by mouth. But I found it interesting to think about subcutaneous administration of cannabinoids, something I've certainly never done in my practice. I'm not sure, Patricia, have you ever heard of subcutaneous cannabis before?
No, but I was thinking that would be a great mode of administration for someone who's having persistent vomiting. I mean, that would be great to use, but no, I have never used that or seen that used.
Probably inhalation is a good one too. You know, like nobody wants to take a pill or a tincture when they're vomiting or nauseous, but and if inhalation wasn't effective, this might be something we see in people in the future. So this is a follow-up study. They've looked at CBDA for nausea and vomiting before, and what they found is that at just fractions of the dose required for CBD or THC, they can mitigate nausea and vomiting with these just tiny doses of CBDA. And in this study, they were wondering, does this treatment persist over time, or do they lose efficacy either when taken 7 days in a row or once a week over 4 weeks? And what they're really focusing on here is this group is looking to develop a cannabis-based drug for treating chemotherapy-induced nausea and vomiting. And so that would be maybe similar to like once a week for 4 weeks. Now check out these doses. They use CBD at 5 milligrams per kilogram of the rodent's body weight. The CBDA was 1 microgram. So that is, I don't even know the math here. That's like 1/5000th of the dose of CBD. It's a tiny dose. And then they also used a stable version of CBDA called the CBDA methyl ester, also known as HU580, at the same tiny dose. And all were in a tween 80 plus saline solution. And tween 80 is it's a carrier for certain drugs. It's like a surfactant, and it's relevant in this study. I'll tell you why in just a minute. But let's take a look at the results here. So here's CBD at this much higher dose. I mean, 5 milligrams per kilogram isn't super high for a rodent. It would translate to, you know, kind of a low dose for people, and that worked very well for treating acute nausea. On repeated treatment, it still worked. It just worked a little bit less, but it still worked. When it was administered with this compound here, WAY, this is a blocker of the serotonin receptor, the 5-HT1A receptor. And so what they're showing here is that the anti-nausea mechanism of CBD is due to its activity at that serotonin receptor, because you can see that the serotonin receptor blocker almost ameliorated, like it just kind of took away all of the effects of CBD. Now over here, we have the super tiny dose of CBDA, which you can see also worked well acutely and repeated, and was also blocked by the serotonin receptor blocker. And then over here, same results basically with the methylated synthetic version of CBDA. The reason this methylated version is appealing, not necessarily to me, but to these researchers, is because it's stable. So CBDA, as most of you know, will convert into CBD if it gets heated, or even at room temperature over a long period of time, it'll gradually convert, and that would change the property of a medicine, making it kind of unlikely for pharmaceutical development. But those of us that are not as interested in pharmaceutical development, more interested in home remedies and artisanal remedies, are just fine with CBDA. So there are some minor gender differences in this study. So you can see that it looks like in the female rodents, both the CBD, well, this slide is just showing CBD. So it looks like CBD worked better, but this is a real interesting one that they didn't talk a lot about, probably because this is well known, it's been shown before. But check this out, 4 times higher dose of CBD, so 20 milligrams per kilogram of CBD did not work as well as 5 milligrams per kilogram. So again, this is one of those biphasic effects where, yes, the higher dose works, but it doesn't work as well as the lower dose. This has been shown in animal and human studies with CBD's effect on anxiety as well. So more CBD is not always better, more cannabis is not always better. I think that this research group really understands that and is looking actively for that sweet spot in terms of dosage where it's not too low and not too high. And it's just, to me, amazing that they had the courage and understanding to look in the single-digit microgram per kilogram range. So I did want to just talk about this tween 80 solution. This is a study that we covered in the webinar back in December of 2019. And it was looking at a few different things, but one was how well does CBDA and THCA and some of the other cannabinoids, how able are they to cross the blood-brain barrier? And so they report this in something called a brain plasma ratio, meaning after administration of a compound, you see how much is in the brain and then how much is in the blood, and you make a ratio out of that. And basically, this was the brain permeability of CBDA was increased by 47.5-fold when given in this tween 80 solution versus when given in vegetable oil. How relevant is this clinically? I don't think so, because you could very, very easily take 47 times a higher dose than 1 microgram per kilogram. Actually, I think it's going to be pretty hard for anyone to take 1 microgram per kilogram. They'd have to, basically brush up against a hemp plant and walk away from it. It's just such a tiny dose. So I don't know that anyone on the webinar tonight needs to be interested in taking tween 80 in order to increase the brain permeability, but it's just something to report that influences the results of that study that we just covered. So I will pause there, Patricia, because I know you, among a lot of the clinicians that I know, are one of kind of the other foremost proponents and observers of the effects of the acidic cannabinoids in your patient population. So I'll just use this study. We could talk about CBDA and nausea, but please, in general, comments about cannabinoid acids.
Well, I use a lot of CBDA. It's a good anti-inflammatory. It's a COX-2 inhibitor at certain doses without the cardiotoxicity. I use it a lot for inflammatory pain. So most of my chronic pain patients, if we're using any CBD, I try to find CBD preparations that do have some CBDA. There are some patients I have them make their CBDA when when they need to do that. And I also use it, I have found it to be very helpful in inflammatory bowel disease. So any patient that I'm treating for Crohn's disease or also ulcerative colitis, I just think that the symptomatic improvement and overall improvement is just better and faster when they use a CBD-CBDA combination. And I'm not sure which is doing what, but that CBDA definitely, you don't need much of it for sure. And the patients, I've had many patients who not only do they have better symptomatic relief and quite quickly, but within, I would say, a year to year and a half, I've actually seen colonoscopies normalize. So they may still have an inflammatory response in the intestines, even though they're feeling better. But ultimately, these are pretty chronic, difficult to treat patients. Most of them are referred. So I'm very happy with CBDA. I use it a lot.
Thank you.
Mm-hmm.
I agree with you. I think if possible, it would make sense for any CBD preparation to include some CBDA. I haven't come across a reason yet for it not to include a little CBDA. I think that just makes a lot of sense. It seems like these two agents are very similar. Certainly, at least at the activity at that serotonin receptor, which is probably the major mechanism of action for anti-anxiety and anti-nausea and mood elevating and maybe some of the other benefits of CBD. They're working on that same target, but it looks like CBDA more potently, or at least maybe more bioavailable to do so, or both. So keep your CBDA or make your hemp tea. Let's move on. This is a randomized controlled trial with 65 overweight and obese men and women from Ohio who were otherwise healthy, given an extract of hemp that contained 15 milligrams of CBD daily. So this is a pretty low dose for 6 weeks. And they looked at biomarkers of stress resilience, cardiovascular disease, and so forth. They looked at a lot of things, actually. I thought it was very interesting. Well done study. The major result that they found was that this very low dose of CBD improved HDL cholesterol levels. This is the so-called good cholesterol that you want to have higher levels of. And it wasn't a huge increase, from an average of 54 to 57.5, but it was statistically significant. And so, I think people often think about taking a low dose of CBD as a general health supplement, right? Very often in this forum, we talk about not just cannabis for treating chronic disease, but cannabis for staying healthy if you're already healthy and you want to stay that way. And I think that this is one nice example of maybe a beneficial side effect people are getting from their CBD, is that it might be improving their lipid levels. There were no adverse effects at this dose of 15 milligrams, no change in many other variables that they studied. Just looking at the CBD group, not in comparison with the placebo group, but looking at just the CBD group from baseline to follow-up, there were some fairly statistically significant improvements in the way they endorsed I get pleasure from life. That improved. The ability to cope with stress, their quality of sleep, and their quantity of sleep. And they were taking CBD, I believe, in the morning. So maybe just having a less stressful day or less stress in general over time improved their sleep quality. And that's all I have on that one. So I'm not sure, Patricia, any points of discussion there. Have you seen lipid profiles improve? Or, yeah, what are your comments?
I don't draw them myself because I'm not doing primary care, but I often have patients come back who are now off their statins, or we use CBD because they are sensitive to statins and they seem to do fine. The other thing that I see is that oral hypoglycemic and insulin levels tend to go down, and CBD is involved in both lipid and glucose metabolism. So yeah, I see that quite frequently. I've had patients come off of insulin using CBD for something else, for chronic pain or seizure or whatever. Yeah, so I haven't looked specifically at the HDL, LDL values, but they often come back off of the statins because they don't need them anymore.
That's great. Thank you. Yeah, and I don't have many other comments. I'm not following lipids closely in my patients either. And you know, this study that I presented here, it looked at heart rate variability, which is an interesting one. That's a way of measuring someone's autonomic tone and whether their sympathetic and parasympathetic nervous system, like the rest and digest versus the fight or flight nervous system, how imbalanced they are. They didn't see any changes in that, but it was thoughtfully done. And I think that it's asking the right question, which is, if people are thinking about what's a kind of natural tonic, what's a health promoting supplement, you know, am I going to choose hemp? Am I going to choose curcumin? Am I going to choose, you know, what is it? Ashwagandha? I think that there's, you know, certainly a different answer for different people based on their constitution and their history. But I think that for a lot of people, low dose CBD may be that. It may be a health promoting daily supplement.
And when you look at things that really contribute to chronic disease, like insomnia, stress, anxiety, diabetes, obesity, CBD can be quite helpful. I also see a good amount of weight loss because it seems to be a natural appetite suppressant, just the opposite of THC. So there are a lot of good reasons to take a little CBD every day. Yeah.
Yeah, I agree. I do see weight loss also. I have people reporting the appetite suppressing effects of CBD, absolutely. And maybe there's indirect appetite suppressing effects also, because so many people are eating because they're emotionally reactive, and if CBD is mitigating their anxiety and making them feel, what was it? I get more pleasure from life. This is an interesting one here. You know, this is talking about capacity for a hedonic response or pleasure response to basic things in life, not necessarily, you know, potato chips and, you know, other things that are maybe not as healthy. So I think that's a good sign. Okay, let's take a look at the association between recent cannabinoid use and acute ischemic stroke. You know, just as a background, I think stroke is, I think, the 5th leading cause of death. It's a really common cause of death. And there's been, you know, some discussion back and forth about, is cannabis use associated with stroke or not? And some data has suggested that there's a higher rate of stroke right after smoking cannabis, and maybe not in cannabis users in general. But what this data looked at was 9,350 people who had a positive urine, or excuse me, 9,000 people who had had a drug screen during a hospital admission. 18% of them were positive for cannabis. So what they looked at was an unadjusted risk ratio, I mean, not controlling for their age or their gender or their background in any way. The unadjusted risk ratio showed there was a 50% decrease in the risk of stroke among those who tested positive for most likely THC in their urine. So then after they adjusted for all these other factors, age, race, ethnicity, sickle cell disease, dyslipidemia, hypertension, obesity, and so forth, there was no difference. So, and let's see, we'll come back to what I make out of this data. Cannabis use was more prevalent in men and younger people and African Americans and in current cigarette smokers. And so you could see some of these may predispose toward a lower rate of stroke, like being younger, but certainly more cigarette smoking would lean it more towards a higher rate of stroke. The proportions of atrial fibrillation, hypertension, diabetes, dyslipidemia, family history of stroke, personal history of stroke, obesity, and other cardiac diseases were lower among those with a positive cannabis test. So, you know, what does this mean? You take a snapshot of everyone coming into a hospital over a period of time. Those with a cannabis use history seem to have better health. They seem to have less stroke, less of all these risk factors for stroke. You know, what's going on here? Maybe the cannabis is protective. We know that cannabis users are less likely to have diabetes, less likely to be obese. We just saw that they might have better lipid profiles in their blood. Or maybe this is not a direct causal association. Maybe it's just because cannabis users are more likely to get better exercise and be happier and get better dancing in, or more, you know, a healthier diet. Who knows what the other associated factors are? Maybe it's some combination of the two, but I'm always very interested. Again, this is the topic of cannabis for health promotion and disease prevention. And is this some evidence that cannabis could be promoting health and preventing an extraordinarily common disease, stroke? And I think the answer is maybe, but it looks like an association here. Your thoughts, Patricia?
Oh, no, just it doesn't surprise me. And I mean, there have been studies looking at cannabis users and shock trauma and being post-stroke and having smaller areas of damage to the brain, as well as to heart muscle. And both of these have also been shown in mouse models. So, you know, the U.S. Department of Health and Human Services has a patent on cannabinoids as neuroprotectants, and that's what they do. You know, they limit the amount of damage done after an anoxic event or a lack of oxygen to the area of the heart muscle or the brain, and it's seen clinically. So,
right. This data set didn't give them a chance to find out, well, did the cannabis users who had stroke have better outcomes than the non-cannabis users who had stroke? Other data has shown this, but this data didn't have that in there. But I would, you know, so think about preventing stroke maybe more in relation to the cardiovascular health. And then probably when someone does have a stroke, if cannabis is in their system, it's very likely that it's going to help protect them from the damage of stroke. And a huge amount of animal data confirms that. Now, I will say that there's been numerous attempts to find acute treatments for stroke, right? Right now we have no what we would call like a neuroprotective approach. You go to the emergency room with a stroke, the one thing that you might get that could really help is a clot busting drug, a thrombolytic, which also has a very high risk to it as well. And so if there's a clot that's killing the brain and you dissolve it, yeah, that can save a lot of brain damage. But there's, in anyone that has a stroke, there's this 2 or 3 day period that follows the stroke where the damage actually gets worse and worse. This is called a penumbra effect, and it's essentially the dead cells are leaking their contents, and that causes an ion gradient that makes it really damaging for the surrounding healthy cells. And they start leaking their contents, and this proceeds. If we can sit there and watch this damage spread, and have nothing that we're able to do about it. So there's been hundreds, literally, of treatments that have worked in animals that have been tested in people that have not worked. So it's a really challenging area for translation from animal research to humans, and I'm not sure why. There's papers about it, but I haven't read them. But I do believe, and probably some of you have heard me say this before, but if I ever have a brain injury or stroke, my family knows exactly what to give me as soon as possible. Okay, let's move on to the next one. This is an association between cannabis use and healthcare utilization in patients with irritable bowel syndrome. So very common condition. This is 5 years of data just looking at diagnosis codes for irritable bowel syndrome and cannabis use. And they include all the cannabis use diagnosis codes from just regular use to problematic use or whatever. But all of these would be people that self-reported their cannabis use or that had a positive drug screen for cannabis. And so they compared data from 246 cannabis users to over 9,000 non-users. And what they found was that cannabis users with irritable bowel syndrome had less often the need for an upper endoscopy. They had a lower endoscopy less often. So this is the procedure where they put a scope up or down the GI tract to take a look around. They had a shorter hospital stay, almost an average of 1 day shorter, and much lower hospital charges. So, this could mean a few different things, but to me it means that it's likely that the cannabis users have less pronounced symptoms and the non-users have stronger symptoms that warrant a more aggressive workup and treatment. Also, some other factors here that I think influence the data quite a bit. The cannabis users tended to be younger. They tended to have more alcohol abuse, but less diabetes. And this pretty much shows up in every cohort where you look at cannabis users versus non-users. You see quite a bit less diabetes. Cannabis users also had less hypothyroid, less hypertension, but a lot more psychosis. So more psychosis and more alcohol abuse in the cannabis users. And that's a really high number there, which doesn't make a lot of sense to me. But anyways, these findings are likely attributable to the effects of cannabis's active compound THC on gastrointestinal motility and colonic compliance. The role of cannabis in the treatment for IBS has potential for significant impact at the individual and population level, given the burden of IBS on individual quality of life and healthcare expenditures. And I just really love that these authors were willing to point out that it's likely THC that's having this beneficial effect. So Patricia, any comments on cannabis use in people with irritable bowel syndrome?
Well, yeah, I would say that a lot of my irritable bowel syndrome patients, again, they may use some THC, and some of that I think has to do with the area I'm in, that it's a little bit more conservative, but we use a lot of CBD too. I think both of these cannabinoids are antispasmodic, and so they may help with, and certainly CBD in particular can modulate GI motility. So I find it helpful for patients who are IBS with constipation and for patients who are IBS with diarrhea, because it seems like whatever they have, the cannabinoids kind of balance things out, so that if they're constipated, it seems to speed things up, and if they're having too much output, it seems to slow things down. And it certainly seems to be really work really well for visceral pain or for that pain that they get from intestinal, spasms.
Absolutely.
As well as address the stress and anxiety that precipitates a lot of these symptoms.
That's right. So much of IBS is part of the gut-brain axis. It goes in both directions, right? IBS could be causing anxiety and depression, or it could be a result of, but it's usually a little bit of both, I think. This study is capturing the people that are cannabis users. We don't know if they're using it therapeutically, as well as they could, but my guess is that these are pretty severe cases. Like if you have IBS and you're using cannabis and you still need to go to the hospital, that's probably a pretty severe case of it, and still doing better than the non-users. So say someone comes to you with a primary complaint of IBS, and I know this is such a loaded question because every individual is different, and we try to treat the individual and not the person. But what are, you know, in terms of cannabis, the tools that you're thinking about recommending, say, at an initial visit?
Well, I'm going to, most of these patients are working and driving, so I generally will start with maybe like a 10 to 1, somewhere between a 10 to 1, 20 to 1 CBD to THC ratio. And with any cannabis product, I don't care what it is, or even when they change medicines, I always have them start with just a little bit and then just gradually titrate up, because it's not, everything is not the CBD or the THC. There's so much else in these tinctures and flowers that we don't know how they're affecting the symptoms. And so the dosing can, from one CBD product, let's say, could be completely different for another product, depending on which flavonoids and terpenes there are and whatever else is in there that we don't know about. So I generally have them start with that, along with a FODMAPs diet, and if they're not already on one, and just gradually increase. And if we're not getting anywhere with that type of ratio, then I start to gradually increase the THC. It's really not that different from how I approach most problems, unless it's something that really, that I feel really requires THC, like for, let's say, nightmares or bad memories, or a tremor from Parkinson's where they haven't responded to CBD, and I generally will start those on THC. But oftentimes these IBS patients have something else going on that we're treating as well. It could be fibromyalgia, it could be migraines. They all kind of come together. And if it does reflect a kind of basic endocannabinoid deficiency syndrome, then having a little THC to directly activate those receptors, but also having CBD to try to increase their endocannabinoid anandamide through FAW inhibition, it seems to work well. So it's kind of it's a little of this, a little of that, a little diet, a little mindfulness, all that.
Yeah. And how about inhaled versus oral, like in people that are having, you know, GI symptoms, whether it's IBS or IBD?
Generally, it's difficult for inhalation during the day when you're at work. And certainly, you know, if they're having, you know, like severe muscle pain, severe abdominal pain, that abdominal cramping, they can try inhalation. I'm in a population that is not, and I see an older population as well, so they're not as enthusiastic about inhalation. But you know, I always say, you know, if you're having severe pain, severe symptoms, you need something in quickly, inhalation is the best way to go. And then follow it with a little oral mucosal so it'll last longer.
Absolutely. I agree with that. I think earlier on in my practice, you know, way more of my patients were using just inhalation and not oral, and reporting these remarkable responses, but probably not as sustained as they would be if using oral. Now it's kind of switched, and I'm also seeing more conservative, more elders, and, you know, more people that have never tried cannabis before, and we get them started with oral dosing, which is effective. But I'm, you know, each day I'm in the clinic, there's probably one or two where I'm having a follow-up visit where I'm bridging that conversation. I think it's about time we try some inhalation to take your results to the next level. Because when these breakthrough symptoms are super strong and they take 1 or 2 puffs and 5-10 minutes later, they're experiencing like a 0 or a 1 on a scale from 1 to 10. That's really profound.
Absolutely. The other thing about GI symptoms that I've found is that patients tend to gravitate to capsules, and they do seem to be more effective. And I don't know if it's because they're poorly absorbed and they're, you know, acting locally, almost like a topical, except in the intestinal lumen. But yeah, and those last, the symptom relief also tends to last longer. But yes, I'm for inhalation as a treatment for something where you need something in quickly. I tell you, that's your IV cannabis. You know, so if you need it in quickly, you're having severe pain or discomfort or a panic attack, by all means, you know, if it's feasible, that's the best way to go.
I agree. All right. Oh, and then one other comment that I want to make about that, and we know so little about this, but if for a long time, probiotics have been one of my treatments of choice in people with irritable bowel syndrome, or often in people with inflammatory bowel disease. And they seem to help, but you know, maybe not for a long period of time. You know, basically, if people stop taking the probiotics, then the benefits seem to go away. But what's really interesting is that one of the ways in which these microbes, these bacteria that live in our gut, communicate with our immune system and with the rest of our body is through the endocannabinoid system. They're speaking an endocannabinoid system language in our gut. So they're changing the receptor expression and changing the amount of endocannabinoid production depending on what species are there. And those bacteria in our gut not only affect the function of the gut, but so many other things in our body and in our brain, including our metabolism and our weight and level of inflammation systemically, and so many things. So
there may have some influence on the ratio of beneficial to non-beneficial bacterial flora. You certainly can influence that with a plant-based diet and kind of moving away from animal protein. But I've read something where that some cannabis users were tended to have a higher ratio of the more beneficial bacteria versus Bacteroides or some of the other pathogens, except for, I think, for chronic smoking. And then with the chronic, or with what they describe as heavier cannabis smokers, their floral ratios tended to mimic more of cigarette smokers. So it may be something about the smoke itself as opposed to the cannabinoids.
Very good. All right, moving on. Migraine frequency decreased following prolonged medical cannabis treatment. So this is a cross-sectional study, which means they basically just took a population of 145 patients with migraine and gave them all a questionnaire asking about their cannabis use and their migraine experience. And so on average, people in the study that were using cannabis had been using cannabis for around 3 years. That's a nice long period of time. 61% of the responders had more than a 50% reduction in the monthly migraine attack frequency after they started medical cannabis. So looking at how many migraines they were having before they started cannabis, and then on an average, 3 years after using cannabis for that long, they're maintaining a greater than 50% reduction in their symptoms. And that's more than half of them had that much of a response. Responders consume, now this is interesting stuff. You guys are thinking, what the heck is MS-373-15C and 331-18D? Well, these are actually cannabinoids that haven't been properly named yet. So as you can tell from the heading on the slide here, this is out of David Mieri's group in Israel, and they're typically going about 100 cannabinoids deep in their analysis of these different varieties of cannabis and the different preparations of cannabis. And they only have a certain number of cannabis varieties in Israel in the medical system. And so they have an understanding of what the patient's taking, and then a very, very deep look at what the cannabinoid profile is. And this group is looking to see, you know, outside of these kind of 8 or 10 cannabinoids that most people are looking at, are there some trace cannabinoids that are big actors that nobody's paying attention to? And we covered one of their studies on cancer several months back, or maybe that was last year. But what they found was that the people that responded were more likely to consume higher doses of this one cannabinoid, which who knows what that means. And also they consume lower doses of this one other cannabinoid. So, you know, here's a look at what they're checking for. So on the right side here are all the different varieties or strains. And then on the bottom here, these are some of the cannabinoids that they're just reporting in this chart. They sure are testing many more. And then they were plotting that against who responded and who didn't respond. And that's what they came up with here. So you can see for the 373-15C cannabinoid, the responders had a lower dose of that. Oh no, excuse me, a higher dose, more responders in the higher dose versus the other one. So not really clinically applicable, except for the basic observation that people can use cannabis to treat migraine for a long period of time and sustain their benefits in terms of reduced frequency. And I think that a lot of migraineurs think of cannabis as an acute treatment. They'll start to get their migraine and they'll take the cannabis right away, often in inhalation form. And if they can catch it early enough in the process, then they're either able to abort the migraine or kind of make it plateau and not go into full strength. But I think also looking at monthly frequency is very important, and it seems like regular cannabis use for a lot of people, 60% of people, can reduce their monthly frequency by quite a bit. So Patricia, what's your experience with cannabis and migraine been like?
Well, actually this week, it seemed to be migraine week. I just saw a patient that I've been following for about 4 years who half the month she was having chronic daily migraines. And this is a over 60-year-old patient who depends mostly on inhalation, and she uses, for the most part, a variety that we have here that's a 1-to-1 CBD to THC, and then she will spot treat with a THC dominant flower, depending on whether it's daytime or evening. But her like half the month of daily migraines has been reduced to maybe 3 or 4 a month, and this is 4 years. I encourage her to try something oral mucosal and to cut back a little bit on the inhalation, especially with this, with their age and concerns about respiratory illnesses and the cilia and the airways and that much smoking. But she's done beautifully. And another I saw today she's 3 years out, who was having 3 or 4 migraines a week, and she's down to 1 or 2 a month. And she uses mostly tinctures and just uses inhalation for when she feels an aura or prodrome. I don't remember I think she has a prodrome where she can inhale when she feels that. And both two use, and I also recommend this, is I don't know about these local receptors, and it probably has to do with just relieving some muscle spasm, but if their headaches start in the back, I have them use a topical and massage it into the posterior neck muscles. If they have more of a frontal headache or a bitemporal headache or one side or the other, or clusters, I have them use a topical as well. So I just try to get them to hit it from a number of different angles. But I've had so much benefit. I've seen a lot of benefit from using cannabis for migraines. It decreases the frequency, the duration of the headache, and the severity of the pain. So when we look at pain scales, where they were 20 out of 10 or 8 out of 10, oftentimes the pain level isn't nearly as high as it was before they started using cannabis.
Have you ever had patients tell you that they'll inhale cannabis and the migraine gets worse?
I have not. Okay.
I have heard that a few times. Go ahead, I'll let you finish your comment.
I think that though that may reflect dosing, or the degree of dosing, and we're back to the biphasic effect of these cannabinoids. A little bit may help, a little bit more may help even better, but if you overshoot that, it can not help as well, or it can make symptoms worse. So, and I generally steer patients to, if they're going to use inhalation, I try to keep them in lower THC percentages, like more like if they can get it 15% or lower, then I think there's less likely that they'll take too much. But that might be that it's too much, or that if they're smoking, then perhaps there could be some degree of maybe vasospasm from increased carbon monoxide levels. Who knows?
Sure, or some of these other hemodynamic changes like heart rate and blood pressure. The people that have told me that over the years usually talk about the timing. So if they catch it right at the beginning, cannabis can make the headache better. But if they spend too many minutes thinking, am I really getting a migraine now, or is it not a migraine? And I really don't want to smoke now because I'm trying to be productive or whatever, and they put it off too long and then smoke too far into the migraine, it might make it worse. And maybe there's already this hypersensitivity or vascular, dynamics going on in the brain that it provokes. But based on that, my advice to my migraine patients is to get it as early as possible. Like you said, during a prodrome or an aura would be much better than after they're already really suffering. Right. Like for most conditions. Okay, the last one on our long list for tonight, and then we'll get to Q&A, which I'm very excited for. So this was a Judahite, or an Israeli shrine, the Shrine of Arad, from 750 before the Common Era. So this is, over 2,700 years ago. And what they found was in these ruins, a smaller altar that had residues of THC, CBD, and CBN on it, along with an assortment of terpenes and organic residues attributed to animal dung, suggesting that the cannabis resin was mixed with dried dung to enable a mild heating. And then there was a larger altar that had remains of frankincense in it. And I'll show you what it looked like when they first found it. So by the way, this is the part of the temple that they call the Holy of the Holies. This is where the Torah is kept. This is, only the high priests or rabbis can go in there. This is a very sacred area. And it's these, I hope you guys can see my mouse, it's these two columns here that were laid down on their sides that contain the resin. And you can actually see a little bit of that resin there. That's cannabis resin. And then as it was reconstructed in a museum, again, you can see the top of these columns where they were burning the cannabis and burning the frankincense. And I think it's very clear that this was burned in the temple for the purpose of improving the spiritual psychoactive experience. And I just love to use that as a segue because certainly we're not rabbis or priests, but I think a lot of our patients are experiencing like a soul sickness, a challenge in their spiritual life or their connection with others, their connection with the universe. And that if that's the case, it's certainly appropriate for us to help them with that problem. And just curious your thoughts, Patricia, on cannabis as a spiritual tool. And if you bring that up with your patients and how you go about that.
I can't say that I've necessarily brought it up as a spiritual tool. I have brought it up in terms of that a certain amount of that intoxicating effect can certainly be healing for a lot of patients. It can be a respite from severe chronic illness or severe pain. It's okay. I think what I say is if you feel that effect and you enjoy it, then enjoy it. Now, not everybody has the same endocannabinoid system, and I have a lot of patients who actually experience dysphoria, so we try to avoid that, but I think it can be very helpful for patients. There are a lot of, it seems to be very popular now for certain types of yoga and other meditations and mindfulness or mind-body techniques. So I think that if you get enjoyment from it, it helps you relax. It helps you get in tune with whatever it is you need to get in tune with. And it's not interfering with your daily living, then go for it. I'm all for that.
Thank you. Well, this goes along with the way that I approach people who want to have an only non-psychoactive experience with cannabis, which I'm very happy to accommodate. Certainly, during the day while they're working and trying to be productive. But if it's somebody where I sense that they would benefit from a greater experience of connection, whether they are, involved in a religious or spiritual practice and maybe not getting enough out of it or just don't have that part of their life, what I'm usually encouraging people to do, and this is, more often the elders in my practice, but not necessarily, is that bedtime dose of THC, take it around supper time once a week, instead of taking it at bedtime. And turn off the screens and put on some relaxing music or whatever it is and just see how you feel. Because usually if someone's titrated their THC dose to correct a sleep disturbance, I find that that same dose will produce a very mild psychoactive and pleasurable experience if they're awake during that. And usually I get people that are coming back and saying, wow, that's what it was like. You know, like when they came to me, they were so like absolutely sure they never wanted to get high at all. And then they come back and say, wow, that was really pleasant. I didn't expect it to be like that, you know? And I think just that maybe a once a week or even once a month to get into that psychoactive state of cannabis, I find it to be extremely healing. And maybe in my experience personally and with many of my patients, one of the most healing aspects of cannabis, that shift in consciousness that can help us learn things and change the way we see the world. Like changing our perceptions of the world can change so much about our individual experience and our physical health as well. When we change our perception, it changes our amygdala stress response, changes our hormone levels. I mean, within seconds, if we change our perception of the world, we can have a complete different hormonal picture and brain chemistry and physiology. And I think a lot of those benefits persist after that psychoactive state resolves. I think that they're left behind in many cases, especially if they're working towards that. So this is nothing new, what we're doing here. You know, it's been going on for at least 2,700 years, but probably a lot longer than that. And, you know, if we think about Orthodox Judaism as potentially a very conservative group that might not be aligned with using cannabis for its psychoactive effects, think otherwise, you know, be open-minded about this. There's probably been cultures all over the world that have been using cannabis to help people spiritually, to help them access.
Cannabis, one of the ingredients in the holy anointing oil and the recipe that God gave to Moses.
There's a lot of people that think that. Yep. And that's interesting. I'm not certainly an expert there, but there are some scholars that think that this is more evidence that translation was a translation for cannabis. You know, I think there's controversy about that recipe for the holy oil. Was it cannabis or were they talking about something else?
Or sweet calamus, but the word I believe is cannabisum. And I had a conversation with Michael Dorr, who is the Minister of Health in Israel, and he was very wholeheartedly supportive. Oh yes, I think that was cannabis. I said, okay, so.
We know that topical cannabis oil has some pretty nice effects, so yeah, I wouldn't be surprised. All right, let's wrap this up. Okay. Oh, sorry. There was one other study. Not that I really want to cover it, but I just want to point out this paper to people that are interested. This is a review article that just came out that's intended to serve as a reference for clinicians so that the risks and realistic benefits of medical cannabis are better understood. This is out of some researchers in Utah. And I really like this. I think they did a great job of staying balanced. They weren't pro-cannabis or anti-cannabis, and they were very concise in the way that they summarized the clinical data and showed what's available currently for all of the conditions that you see here on the screen. And so I encourage anyone that wants a concise review. I think comparing this to, say, the 2017 National Academies of Sciences, Engineering, and Medicine volume, of which just a part was related to the clinical use of cannabis. A big part of it was related to the non-therapeutic use of cannabis. But I found this to be actually more useful than that review. So a good one. And then these were their conclusions. Based on data identified, the most robust evidence suggests that medical cannabis can be effective in the treatment of chemotherapy-induced nausea and vomiting, seizure disorders, multiple sclerosis-related spasticity, and non-cancer pain, excluding diabetic neuropathy. Across all studies, the most common dosage of THC ranged from 2 to 30 milligrams daily. I'd say that's pretty similar to what I see in my practice. And CBD dosage ranged from 0.5 to 20 milligrams daily, which is probably lower than what I see in my practice. What do you think, Patricia?
I would say those doses are more in keeping with what I see. And I know that that a lot of CBD doses are higher, but a lot of those products, I don't know that they are full spectrum. I think that with the full spectrum extracts that you really can get efficacy at a lower dose. And then I use a lot of CBD with CBDA, so that too may lend it to not needing as much. I don't really recommend that many tinctures that are isolates, just because I think that you will get into higher doses and you don't see the same efficacy. Like I have a few seizure patients who were on, taking 2.5, maybe 2.5 milligrams per kilo. And these are, little 20 pound and 20 kilo patients. So I don't think there's some studies that show that you need tons of CBD, but I think we think about it as just CBD or just THC, and it's so much more than that. And it's those other compounds that influence the dosing. That's why I just don't see how we'll ever get dosing under our belts, because each medicine is so different.
And each person is so different.
And every person is different, yeah.
Do you ever have a reason for recommending CBD isolate over a whole plant extract?
No, but it came up recently that a question was asked about a patient with colitis who was experiencing allergic reactions to whatever Cumavar he was using. He was getting good results, but he was having it sound like an IgE response. And my suggestion was to try a CBD isolate or a CBD CBDA isolate, or a THC CBD isolate, where that just had the cannabinoid suspended in whatever type of oil he might not have a problem with, be it MCT or sesame oil or coconut oil.
The only time that I've ever recommended that is for someone that feels like they're having a good result with CBD, but who feels like it makes them tired. And in that case, so I'm suspecting that it's not the CBD that's making them tired, but it's probably all the myrcene or something else that's in their whole plant extract. And in, just a few patients, I've had them switch over to an isolate, use it at a higher dose, and maintain that same benefit without that side effect.
That's interesting, because CBD will influence sleep by through adenosine pathways. So a lot of times I will use high dose CBD for insomnia if they don't want to, or if they can't take THC because of, employment and possible drug testing. So yeah, that's interesting that the isolate, you can use the higher doses and not get the sedation.
Great. All right. So then the last thing I want to do is a shout out for one of our sister organizations, Patients Out of Time. Patricia and I are both involved with this organization that's been working hard for 25 years to support patients when it wasn't cool to do so. They've been doing an incredible job over that time. They were instrumental in the investigative new drug program, and those initial patients that are, and there's still a couple left that are getting cannabis cigarettes administered by the federal government in the mail each month. But they've had wonderful conferences every year that bring together clinicians and researchers and activists and patients in this beautiful mix. It's really one of the best. And because of COVID and their inability to have the conference this year, Patients at a Time would really love your support. And so for any of you that have been in this for decades, or for any of you that are brand new to cannabis and you want to kind of pay a little tribute to the ones that got this started, Patients at a Time they've got such long, strong roots in cannabis, and they could really use your support right now due to not having the conference this year. So even just a few dollars, I'm sure, would be appreciated if you could go to patientsatatime.org and donate. That would be a lovely thing to do. And on that note, I am going to stop the slide share, and glad to see that you're all still here. Quite a few of you, actually. Thank you all for joining. Let's go to our questions. So, so we have some questions that were emailed ahead of time, and then I'm looking at some live questions, and I'm gonna start with the emailed ones, and we can just take it from there. So let's start with Susan Johnston. Is there a specific medical cannabis formula and dose for essential tremor? My husband has tremor in his hand and head. Great question. Patricia, what's been your experience in treating essential tremor?
There's no specific formula. I'll start with, again, everyone responds differently. So for essential tremor, I've had patients who have responded to CBD. I think I get a better response with THC, but we've had to use CBD for some patients who can't use THC. Usually it's because of employment. But I generally have them start with a low dose of THC and gradually increase it. You could even try a CBD THC 1-to-1 if you're using it throughout the day and the THC is too impairing. But it's still a matter of starting with a few drops or a few milligrams and gradually increasing it until you see the benefit. Sometimes, and some of the Parkinson patients do well with inhalation with the tremor, and they like it because, and this is generally with THC, that they take a few puffs, their tremor goes away, and especially for the men, they say, "Oh, I can shave, I can eat, I can, you know, do self-care. I don't have to depend on anyone," and it only lasts a few hours. They may be a little intoxicated, but again, we say there's some benefit to that for patients who enjoy that, and then it wears off and their tremor comes back. So Dustin, how do you do it?
You know, I think, first of all, my response rate with essential tremor is probably no greater than 50%. I do see quite a few treatment failures with that particular condition. I have no way to predict who's going to respond or not. I guess 50% is probably way better than any other treatment we have for this condition, except for alcohol.
For FDA approval.
Yeah, yeah. And you know, I say alcohol does often help with this condition, and that's sometimes how it's diagnosed, but it's certainly not a sustainable way to address it. But I do find that for those that don't respond to oral dosing, many of them will respond to inhalation temporarily, and absolutely that's the case with Parkinson's as well. Okay, next question is, I am taking a 1-to-1 THCA CBD formula for wellness. Does the raw form of THC have less efficacy than the psychoactive THC? Wow, what a broad question. So THC versus THCA for wellness. What do you think?
Well, THCA is a good pain reliever. It's an antioxidant, it's neuroprotective, it's anti-inflammatory. It doesn't cross the blood-brain barrier because of that carboxyl group, but it does activate other inflammatory receptors that are involved in inflammation, like those PPAR receptors. I've used it in patients with autism for agitation when they didn't respond to CBD. I've used it. Actually, I have a patient now who came to me and for chronic pain, sort of inflammatory arthritis type. But a couple of months after she first came to me, she was diagnosed with a glioma. And she was having these debilitating daily headaches. And she's a senior and hadn't used THC before. She didn't have any familiarity with it. And we had tried some, and it was a little bit too intoxicating, I believe. But anyway, we ended up with a really good product. It's a THCA 1-to-1. And I don't know if I can mention any names or not.
Right ahead, that's fine. So I'll just cut in here and say that I've been very jealous of Patricia because she gets to practice in an area where her patients have access to the healer medicines. You know, right now Maryland's the only place they're available, not in Maine where my patients are. So she's had the benefit of using a healer formula.
And it's worked miracles. She's gone from daily debilitating headaches to 1 or 2 kind of headaches every now and then. And and I don't know if it's all from an anti-inflammatory effect. I don't know if it's from the analgesic effect or the actual pain relieving effect, or I don't know if it's having an effect on the tumor itself, but she's doing amazing. And I attribute it to the THCA. And before we had this wonderful product, I sometimes had to help parents make THCA tincture for their patients, for their children with seizures. And honestly, I'm not sure exactly how it works for seizures because it doesn't cross the blood-brain barrier, but there must be some other mechanism because there are patients who do respond to it. So I would say I don't know that it has less efficacy than the THC, which crosses the blood-brain barrier. But for wellness in general, there are a lot of other receptors that are activated by that cannabinoid, and they certainly are antioxidants, neuroprotective, pain relieving, anticonvulsant. THCA has a lot of benefits. So how would you answer that?
I think it's a question that just gives us a chance to talk about our beloved THCA, which I think so many people overlook. And it's easy to overlook, not just because people aren't talking about it, but also I think sometimes the benefits are slower to kick in. And so on a single dose of THCA, people might notice less than they do if they're using it repeatedly for a week or more. So it takes a little patience, but it doesn't take a high dose. And I mean,
the patient that I just mentioned with the glioma, she takes 4 drops in the morning and 5 drops at bedtime. And it has alleviated her headaches, it helps her sleep, she's more relaxed. It's worked beautifully.
Great, thank you. I just need to pause for a quick second to give a shout out to someone that I'm seeing here on the webinar who I haven't actually seen in such a long time. Ed Samalian is on, and Ed was my strength training coach in high school, who did so much more than teach me how to strengthen my body. I mean, he just brought a whole spiritual dimension to my life and mentored me, taught me how to drive stick shift. Thank you so much for being here. And you know, for everything that you've done for me. Trust me, a lot of your influence is lasting in my life all these years later. So thank you so much, Ed. And I'm still working out super slow twice a week. I'm still going to failure all the way. So thank you, Ed. Let's go to the next question. What are the main differences in using CBN versus THC as a sleep aid? Does it affect REM cycles the same way, and is CBN as effective as a pain relief option? You know, I'll just start by saying that I don't have a lot of experience with CBN. I don't see those products that often, and when I do, I have some concerns because a lot of them, when they're produced, are produced with very high heat. And even though that's going to help convert the THC into CBN, it's probably doing a lot of other things to the other constituents in there, which may not be good. But I can't really comment on its clinical efficacy. From time to time when people do use it, I feel like it's, I don't see trends. I see some people say it helps them sleep and some people say it keeps them awake, and I'm not sure what to make of it. What about you, Patricia?
The only CBN product we have here is a 1-to-1 THC to CBN. So I don't really know if it's the CBN or the THC or the myrcene or the what is it, the linalool or whatever other terpenes are in there. Because when I think about like some of these, or like an isolate, like a THC molecule like dronabinol, that doesn't necessarily cause sedation. So, and most of the chemovars that are good for sleep are usually heavy in myrcene or nerolidol or linalool or all of the above. So it's hard to say, but there are a few sleep products here available in this area that do have some CBN in them, but I don't know what's working really.
Got it. And the natural CBN, I think, would be more interesting to experiment with, and that would be the jar of cannabis that's been sitting on your shelf for the last 3 years. That's got CBN in it, and that may feel different than it felt after you first harvested it. And so if you have any of that around, you could test it out and let me know what you think on the next webinar, or go ahead and comment on it in the chat, because I think that old medicine, as long as it's not moldy or anything like that, could still be useful and may have some different properties.
And in terms of REM cycles, I think there was some data early on that looked at increasing REM cycles. But I think the latest is that cannabis really does not affect sleep architecture as much as we thought it did. What do you think, Dustin?
You know, I think the main reason why people are interested in using CBN in sleep formulas is because of one study out of the late 70s that found it to be more sedating. You know, it's really similar to THC in its pharmacology as far as we know. It's got, based on also some very early studies, a little bit more activity at CB2 than THC does and a little bit less activity at CB1 than THC does. So maybe it's slightly more psychoactive, but you know, for one little data point to jump to a conclusion that this is the cannabinoid for sleep, I think is just way too big of a jump. And then, yeah, I agree with you. I think in terms of sleep architecture, we still have a lot to learn. We don't have enough sleep studies with cannabis, but I'd say most of the evidence would suggest that the doses that people are using to achieve good sleep without being totally stoned in the morning are doses that are not likely to disrupt sleep architecture. Okay, let's go into another question. I'm going to keep going with the emailed questions for now, and then I'm going to jump over to some live questions pretty soon here. And just for those of you that emailed them in, if you emailed multiple questions, I might just cover one or two of them and not all of them so everybody can get a chance. So this next one is from Sharon Krieger. For Dr. Frye, has there been any success in treating stage 4 esophageal cancer with medical cannabis?
All right, well, I don't treat cancer with cannabis. I have to say that we don't know enough about what it is in the plant that some cancers respond and others don't. I think there's enough data to suggest that combining cannabis with conventional chemotherapy or radiation therapy can be beneficial. And I know that there are a lot of anecdotal and stories, and not stories in a negative way, but recounts of cancers that have gone away when patients were using cannabis, say, in respite care or for palliative care, but we just don't know enough to predict. I don't know of any studies specifically on esophageal cancer, but for any patient with cancer, I always recommend cannabis. I recommend it to mitigate the nausea and vomiting associated with chemotherapy, to help with mood elevation, to decrease anxiety. It helps with sleep. It can improve appetite. It can protect against chemotherapy or radiation-induced neuropathy. But if the cancer goes away while we're using cannabis, I look at that as an added blessing. But I don't depend on cannabis to treat any type of cancer. And for patients who come to me, especially with a treatable cancer, and I've had this happen a few times where they wanted to forego chemotherapy for, let's say, an intraductal breast cancer or something that really with conventional therapy, they have very good success rates. I advise against it. I advise using it as an adjunct, but not as sole therapy for any cancer.
Well, thank you. I think that's the answer for whatever would have been in that question, any type of cancer, right? There's no magic formula for esophageal or uterine or brain or anything like that. And we just know so little about it that I think the best approach would be to have someone listen to their body, you know, and if they're trying to follow one of these cookie cutter type approaches to cannabis dosing in cancer and their body's telling them no because they're getting all these side effects from it, I really don't think that that's a good idea. And so this is covered in the Healer curriculum, I think concisely but thoroughly. And that would be the right approach. There's also ways to, I'd say, watch and see if someone's cancer is responding to any type of conventional or alternative or cannabis-based approach, and that's really needed. I think that anything cannabis can help, it could potentially hurt. And some of these really high dose approaches that might be immune suppressive to some extent might be not good in certain cancers. There's some data out of Israel that suggests cannabis in conjunction with some of the immune therapies like nivolumab or Opdivo is the brand name. That might not be a good idea to combine cannabis with that, but that conversation actually has many components to it. It's not a contraindication. I think it really depends if cannabis is being used to allow someone to complete their course of therapy or to prevent using corticosteroids, which often are given with those types of drugs and would also decrease their efficacy. So there's a lot of conversation there, and I wish there was a simple answer. So many people want the simple answer, but get hooked up with someone that's a good cannabis clinician that can take your case and evaluate you as an individual and not a diagnosis. I think that's the best bet. I will say though that I guess the one other thing, and I mentioned this in the curriculum or discussed this as well, is that there's some people that just don't want conventional treatment. And I respect that. And I do my best to differentiate if that's being driven by love or fear. And so many people have seen a loved one that's died while on chemotherapy and had this terrible effect on their quality of life prior to their death and said, I'm never going to do that. But that person that they watched die may have a very different diagnosis and prognosis and treatment, recommended treatment course. And it's really just not apples to apples. If it's someone that's really not making that decision out of death anxiety, but fully embracing their mortality, feeling thankful for their life and saying, I don't want conventional treatment, but I'm going to use a bunch of cannabis here. What can you do for me? I do totally support that and don't try to push them in. I'm sure you're the same way, Patricia.
Yeah.
All right, let's move on to another question. This is an interesting one, also directed to you, Dr. Frye. Treating a chronic cough for 15 years, diagnosed as the result of acid reflux, but a productive cough without runny nose, not a dry cough, does not conform to accepted description of acid reflux cough, have to take hydrocodone to get through church, choir, concert, speaking, hosting, and engagements. What do you think about treating chronic cough like that?
I have not had anyone come to me with a problem like this. Looking at it, I'm thinking that perhaps if there is reflux, that low dose CBD might be helpful. You have to be careful though with CBD because I've seen it make reflux worse. It can lower gastric acidity and treat gastric inflammation, the inflammation is really the source of the symptoms, not so much the gastric acid. But CBD can also lower the sphincter tone between the stomach and the esophagus. So you have to be careful with it if you have significant reflux. But in terms of an antitussive, meaning to stop a cough, I am not aware of that action. Now, if there's bronchial inflammation, perhaps the use of CBD or CBDA even with a small amount of THC might help with the inflammation, but I don't have any experience with treating a chronic cough with cannabinoids.
Well, yeah, and I don't have a lot of experience either. I mean, my first approach would be to treat this patient osteopathically and let my hands tell me where I think might be the source of the cough, which could be central or peripheral nervous system, inflammation in the lungs itself, or, acid reflux, the postnasal. I mean, there's just so many potential causes. But in thinking about cannabis and cough, a few of my thoughts. One is THC can act as an expectorant because it can change the consistency of the mucus. And so if it's thin mucus that someone's having trouble getting up, it might kind of thicken it and allow them to be more productive. And I guess before I go on with my other thoughts in general, like when you have a rare condition like this that probably hasn't responded to conventional treatment, I do think it's a good idea to try cannabis. It's usually the potential benefits outweigh the potential risks, and it might help. But I would think about it. THC as an expectorant. I would think about CBD, THC, CBDA, THCA as an anti-inflammatory, like Patricia mentioned. As far as the potential for this to be acid reflux, I just want to comment that I'm the most cautious in treating GI conditions without a good workup, because I think probably one of the biggest dangers of cannabis is that it works too well. And you might be suppressing symptoms and delaying diagnosis, essentially. And with GI, that could be bad. There could be an ulcer, you know, there could be a cancer. You know, we had a question about esophageal cancer previously. If somebody's coughing all the time, I want to know what they don't have before I just suppress the symptoms. And I find that to be especially important when it comes to GI tract.
I have used it for chronic hiccups, and it's been effective. And for treating achalasia, which is a spasm of the esophagus. It works, you know, very well for that, but I haven't had a cough, chronic cough.
Thank you. Okay, it is 8:35 on the East Coast. Let's switch gears a little bit into live questions, since those are so fun. And so we'll start with Marilyn Lammert. So Marilyn,
Okay.
I think, oh, there you are. Great.
Here I am. Thanks. So I have a chronic pain condition, really never got, there's maybe complex regional pain syndrome, but anyway, not clear. I've had all kinds of tests. Leg pain, which is worst at night, and it gets worse the longer the night goes along, the longer I lie flat. And so sleep is an issue because, well, you can understand. And I've tried THC. I'm right now taking, I just started with a vape of CBD and THC, but I'd be interested in anything for the pain, I guess, primarily, because I think that's the issue for the sleep. So that's my question.
Great. And I'll just, before we answer, you know, make it clear to everyone that when Patricia and I answer the question, we're talking about what we would do if you were here in Maine or Maryland and we were treating you as a patient. Obviously, we can't treat you in this forum, but we could certainly provide some education.
Yeah,
so tell us a little bit more about what you've tried on the THC side. Have you tried like an oral dose, and how high have you gotten on the dosing?
I haven't gotten very high. I'm very sensitive, so that I get the psychoactive qualities affect me. I used to try it during the day and I just couldn't because it interfered with my life. But it really, the issue is more at night. So
on the THC dosing, and you know, the number of milligrams is less important because, as you said, you're sensitive and everyone's different. But have you tried increasing the dose of like a THC oil or tincture to the point that you're getting psychoactive side effects? And at that dose, have you still failed to get some pain and sleep benefits?
I don't think I've done that. I mean, yeah, I don't think I've done that. I mean, during the day when I did it, it didn't seem to affect the pain, and I was getting the psychoactive benefits.
Okay. Well, so, and just, you know, for everyone that's listening, what I'm kind of fishing for here, what she answered, is the therapeutic window of THC. So did she reach the upper limit of that window without a therapeutic benefit? And that, if that's the case, I would switch gears and try something else, or try adding something to THC because it wasn't effective on its own. It sounds like you tried that during the day, Marilyn, but maybe not at night, and your tolerance for the psychoactive effects may be better at night while you're asleep. Of course, the caveat would be to be really cautious of a fall. So you'd want to attend to any fall risk in the bedroom and put a nightlight in the bathroom and all that good stuff.
Yeah, I have that, right.
But so one thing that a person like you could do would be to, you know, gently explore the upper limits of your tolerance to THC as taken before bed. But I think the other thing that came up in this webinar tonight would be a combination of THC and THCA, and give it a chance.
Nobody has mentioned THCA to me. I mean, I work with a pharmacist at our local medical marijuana dispensary, and I've not heard, so I don't know, would that not be available? I'm in Pennsylvania, would that not be available?
If it's not available, you could get flour, and you could learn how to do your own little alcohol extraction and make a THCA tincture for yourself, or you could try making a tea with the flower. As long as you don't boil it too long and too hot, the heat's probably not going to convert all of that THCA to THC. And so if you make a tea with the flower and add some fat to it and sip that, oftentimes, and I learned that from some of my more senior patients in California years ago, that's how they would use the flower when they didn't really like the intoxicating effect from the THC. The other thing you could do is combine CBD with THC, because the CBD will mitigate the intoxicating effect, but it will add to the anti-inflammatory and neuroprotective and pain relieving effect by different receptors. So you might tolerate the THC better by starting with a higher CBD to THC ratio, and gradually, as your body gets used to the THC, you could gradually narrow that ratio and perhaps even eventually go to a THC dominant formulation. So you might just need to let your body get used to the THC a little more gradually rather than trying to go right for it.
Yeah, because what I had was straight THC at night anyway, and it didn't really work. And I just got a combination, but I could follow what you're just saying.
And again, it's more than just the cannabinoid. So one tincture may have a terpene profile that's different from another tincture. So don't give up on it. It's a lot of trial and error until you find the product that works for you, for your receptors. So just try different products. Sometimes you'll find that you'll get a better response from something different. And a lot of times it has to do whether there's beta caryophyllene or limonene or whatever other terpenes are in that particular product.
I wish I used to, 5 years ago, I lived in the suburbs, Maryland suburbs outside DC. I wish I knew of you when I lived there, but thank you.
So, and it was a great question. I think something that so many people can relate to. And, just to summarize the responses that we came up with, one is to make sure you're exploring that therapeutic window of THC, knowing that over time, THC on its own will gradually widen that window, and you'll be able to tolerate higher doses with potentially better efficacy a week or two into treatment than you could on day one. Another comment was the addition of THCA, which you can easily achieve by making tea. Now, what I would recommend for you, since you are sensitive to THC, would be to make the THCA tea by going to the dispensary, asking them what's their best strain for sleep, buying a little bud of it. You can just take a little, or a person like you could take a little pea-sized amount, put it in a cup, and then pour hot water over it, just boiled water over it. Don't add cream or milk or fat to it, because that would, if there is some THC, that'll increase its solubility, and that might put you over the line on the THC dose. But without any cream or fat in it, if it's just water, the THC has almost no solubility. So it's either going to stay in that bud or it's going to stick to the rim of the cup, but it's really not going to be in the tea that you drink. So that would be the best way to avoid going over the line. And then the other comment was to use CBD as an adjunct to THC to allow you to tolerate more of it.
Right. Okay.
Great. Thank you so much, Marilyn. That was a great question and stimulated a really nice discussion. Okay, let's go to Lonnie, who's next.
Unmute. Hi there. Hi, Dustin.
There you are, Lonnie. Great to see you.
Pleasure to see you. And hi, Patricia. I am very happy to get on and ask a question. I've been listening, and I heard you actually talk about two of the questions that I wanted to ask. CBDA for chronic pain. I love that information. THCA and autism. That's a separate question I wanted to ask about dosing, if Patricia might be able to expound on that. But in particular, I wanted to ask about THCV and diabetes. I know we talked a little bit about glucose tolerance earlier. Wanted to see if you could speak a little bit about how to work with patients that are presenting for diabetic condition.
Okay, well, I'll go. Well, THCV is not, we don't have any THCV products available here. From my understanding, some of the African varietals tend to be higher, like Durban poison. I have not used cannabis, at least I have not targeted THCV as a means of trying to lower or to improve glucose metabolism. I depend a little bit more on CBD for that, and nutritional, dietary changes and lifestyle changes. But the Durban poison, I know, is one varietal that has a fair amount of THCV in it, so that might be something that's available to you, or any of the chemovars that are of African origin. From my reading, they tend to be higher, but I don't know of any products that I know they're looking at THCV as a way of as an appetite suppressant, but so by changing your dietary habits, there may be some improvement in insulin sensitivity as you're losing body fat, but I just don't have any experience with it. I'll just comment on THCA for autism quickly, that it is a good anti-inflammatory. It's going to be activating some other receptors in the body. Some of the patients that I have who are have agitation and seizures that don't do well on CBD, THCA is generally the cannabinoid I look at next after we've gotten all we can out of CBD and it's not working, or we've run into adverse effects, which is usually either diarrhea or increased anxiety, or daytime sedation, or sometimes just increased irritability. And then THCA, I have used more. I've gotten, I think, better response with those who have seizures. It seems to me it works better as an anticonvulsant. But for those very irritable kids, I usually will go to a very low dose. I'll microdose with THC and start at about 0.1 milligrams per kilo. And, and I think I got that dose from Dustin a few years ago. So I stuck with it. And then we very slowly titrate up. And sometimes we'll see I have a few, especially young adult autistic patients who've done beautifully with the THC, but I haven't had as much luck with it with the THCA. And it may be because it's a decreased affinity for the CB1 and CB2 receptors. It's not really crossing the blood-brain barrier, and maybe that's that neuroinflammation that we're addressing with the THC and the CBD, that it tends to work a little better, at least for me.
One quick question to follow up with that, if I might. Do you notice with the autistic patients that if you go to a certain point with THC that you might actually cause some depression or agitation? Have you seen that sweet spot happen?
Certainly. You can certainly increase anxiety with if you take the THC too high. A lot of these behaviors, I believe, are anxiety driven. My background in pediatrics actually had a lot to do with behavioral pediatrics, and I did a lot with ADHD and autism and school and behavior problems. And of course, that time I was in California, and I didn't know a thing about medical cannabis. It wasn't even on my radar. I'm sorry it wasn't, but now I use it. And so again, you have to start with those very low doses, but I find the ones that respond to THC respond to very teeny tiny doses. So I haven't run into it, but I have seen increased anxiety and issues even with too much CBD. And for some, even small doses. So each patient is different. And you just have to start with a small dose and just very gradually increase it. And I don't increase doses more frequently than every week or so, because I just give it time to see how this patient's going to respond. So that's how, that's what I do.
Thank you. Thank you so much. That's excellent.
I'll add a couple comments. So, I agree. I think THCV in theory would be the best treatment out of, the world of cannabis that we know about right now for obesity and diabetes. So far, any THCV that I've ever seen comes along with quite a bit of THC with it. That those two aren't separated like CBD and THC are. And THC helps with obesity and diabetes as well. I think anything that gets people sleeping and experiencing more natural reward and maybe moving their body better. And I really believe, and there's a lot of evidence to support that both THC and THCV would have a directly beneficial effect on metabolism. I also go ahead, Patricia.
I was just going to say a misconception is that using THC increases appetite and increases body weight or BMI or body fat. And it doesn't, because while it increases appetite for a lot of patients, it seems to also increase energy expenditure. So you actually see less obesity and diabetes in patients who use THC.
Wonderful paradox.
And then I wanted to make a comment going back to Marilyn before, something I wanted to say that I didn't is that we don't always need to lean on cannabis alone. Cannabis plays so nicely with other herbs. And, it wouldn't make sense from someone with an herbalism background to treat, leg pain and spasticity at night with just a single herb. Why do that when you could combine many of them, kind of nudge the physiology from many directions towards greater health and balance? And so, ideas like valerian, for example, or hops, or, there's many other herbs that also have sedating and antispasmodic and anti-pain properties that I think play very nicely with cannabis. Kava is another one. So, important things to think of. So let's go to our next question, which is Michael M. Do you know how to find your therapeutic window? This is a live question, but he didn't want to ask it. So, the concept of a therapeutic window is, well, there's a certain dose at which you're going to get a response. And then in most people, that dose is below the dose that's going to create adverse effects. And so we think of the therapeutic window as kind of that range where there's some response and there's some adverse effect. And you want to play in that window and see how high you can go and how much of a response you can get before you're dealing with side effects. And the way to find that is just through careful titration. It's got to be methodical and incremental. You start at a low dose that's often subtherapeutic, does nothing, and you periodically increase the dose bit by bit until you get either to satisfactory benefits or until you get over the line and you say, now I got to back up a little bit. I'm outside my therapeutic window. But the real thing that we talk about a lot in the healer curriculum and in cannabis in general is that we have strategies to widen that therapeutic window. So if someone finds that their window's here, but their therapeutic dose is up here and they're having to deal with side effects in order to get a therapeutic effect, we can usually use a strategy to change that by adding CBD or by titrating slowly or changing the delivery method or dose layering. There's many different approaches to helping someone get benefits without any adverse effects, and that's usually possible for people. Okay, let's do another live one, and this is drbo.cbd. Well,
just a second, I'm trying to unmute.
Okay.
You want to jump to the next one? It's not right working.
Okay.
Thanks.
The next one, well, how about I go back? I'm going to go back because I know a lot of people emailed questions and
actually just unmute if you want to go ahead.
Oh, okay. All right, Dr. Bo, are you there? No, maybe not. Well, here's another one. This is from Felicia Dawson to Dr. Frye. What concerns do you have regarding cannabis and nanotechnology, if any?
That's a good question. So we're talking about nanoemulsions that make the cannabinoids more bioavailable so that they're easier to, it's easier for them to be absorbed in a water environment. And while there are kind of two sides to that, I actually do use a water-soluble CBD product for some of my autistic patients who don't tolerate anything but hiding the medicine in water or juice or something that they're drinking. And it's certainly, the dosing is very small. The effects have been quite beneficial. There's some question I think that some people have about, well, if we're we don't know enough about how this is altered at different levels, let's say on a cellular level, but I've been using this now for about about 5 years. And I'm not aware of any adverse effects. It makes dosing very easy for patients who have minds of their own about what they're going to take and not going to take. They don't tolerate oil under the tongue or between the lower gum and cheek. Giving it fully an oil-based product in applesauce, there's no fat in applesauce. That really pretty much impedes or interferes with absorption. If you give it to them in ice cream, there's better absorption, but we're treating an inflammatory situation. So I really don't like putting the medicine in sweets. So it's a dilemma for some patients, and I've had to depend on microemulsions or nanoemulsions. The one that I use though is full spectrum. A lot that are on the market are isolates. I've already expressed that I'm not that excited about isolates, except maybe in particular situations. But for overall therapeutic benefit, I find that the more that's in that product, the better. And I've had some success with it.
Great. Thank you. Yeah, I don't have much to add to that. Let's do, and I just need to apologize that we're going to be wrapping up soon, and we have a lot of questions that we haven't gotten to, and I wish we could get to them all. Thank you for submitting them. We just do our best each time. But let's do another live one before we wrap up. And this would be, I think next in line is Michelle Smith. And maybe while we're looking for and unmuting Michelle, I'll just throw out a previously submitted question that might be somewhat of a quick one. I have had an L4, L5 fusion and have MS. I dab all day. Is there anything else that would help? What do you think, Patricia?
Oh, I think you should take that one.
Well, okay. So, I think that people that inhale really high doses are often building tolerance. So, in defense of dabs, I will say that I have had patients that have severe pain that report to me that there is nothing that ameliorates their pain as well as a dab. No smoke, no other drug, no cannabis preparation, nothing. And I tend to believe them because you get such a high blood level temporarily. And I do think there's some value in getting a vacation from your pain, even if it's just for an hour or something like that, to help the body and the brain reset. But if you try to rely on that over and over again throughout the day, it's basically going to stop working or lose a lot of its benefits. And so that's, cannabis teaching you to use it in a variety of ways. So the common approach for pain would be oral dosing for baseline and inhalation for breakthrough. And if you find that you're building tolerance, to take a tolerance break or go to healer.com and do the sensitization protocol and get a better kind of dose response relationship going.
And I agree with that. I think a lot of that has to do either you're a super duper rapid metabolizer, and that's the only way you can get a plasma level that's effective. But I think for the most part, it's your endocannabinoid system has seen so much cannabinoid that it starts to shut down receptors. So you need higher and higher doses to get a therapeutic response. And like Dustin said, it doesn't take long to reset, just 3 or 4 days. I ask my patients just 3 or 4 days, use something else, and they start over at a lower dose, and they ultimately end up using less or a lower dose than they were before they took the break. And so I encourage patients to resist the temptation to escalate their dose the way we do with pharmaceuticals, that if you just take a break and start over at about 1/3 the dose you run before, you often can get even better efficacy and at a much lower dose. So.
Right. And I do see one here that was previously submitted from one of our really active members, Taru Fisher, which I think it's important for me to ask you this, Patricia, because I don't really know the answer. I mean, basically, it's a question about someone that's using CBD and THCA at a 4-to-1 ratio. And after starting that, experiencing high blood pressure and increased heart rate. Tried reducing the dose, didn't get much better. Changed over to a full spectrum CBD THC, and blood pressure and pulse was okay. So it seems like, is it the THCA that's causing these cardiovascular effects? Have you ever seen anything like that before?
I've never seen that. I don't believe there's much with CBD and the cardiovascular system. Certainly THC can cause a rise in heart rate and a drop in blood pressure for some patients, not all. THCA, possibly. Yeah, I haven't seen it, but generally speaking, watch the dosing because you don't need much THCA. We talked about that earlier. It's you can use teeny tiny doses of it, so check the ratio. Maybe the dose of the CBD that's needed is bringing in too much THCA. I don't know.
You know, one of my first thoughts is that certainly this is possible. Everybody's different. And it would seem like since the CBD THC combo didn't irritate, that the obvious factor is the THCA that was irritating his system. But also, you know, before concluding that, I would absolutely question the labeling and accuracy of what is in that bottle of CBD THCA, because it may not be what it says to be. And I would individually, without any other confounders, try just THCA, like that tea that we mentioned before, and see if independently THCA is the thing that's irritating the person. I've certainly never seen that. On the topic of THCA, I do want to make one comment because you mentioned a couple times, Patricia, that THCA doesn't seem to get into the brain, into the central nervous system, doesn't probably cross the blood-brain barrier, but that would be if the blood-brain barrier is completely intact in a healthy person. But anyone that's having seizures or migraine or mast cell activation syndrome or a number of different conditions may have some impaired function of their blood-brain barrier, which can actually cause like a feed-forward cycle. By having the condition that interferes with the blood-brain barrier, they get more inflammation in the brain, and that makes the problem worse. In those cases, there may be a higher penetration of THCA and other cannabinoid acids into the brain. That's the only theory I've got for how I see seizures respond to THCA.
Yeah,
I'm not sure how else.
I couldn't figure. I'm like, wow, why is this working?
Yeah, I gotta hang my assumption on that one. I don't know what else to assume.
Thank you.
But well, we are at 9 o'clock. I'm not sure. Simone, was there anyone else with a live question that was pressing?
Michelle's microphone is unmuted.
Okay, great. Michelle, where are you?
I'm right here.
Oh, great. Hi, Michelle.
Hi. I just had a quick question for Dr. Frye. Earlier in the conversation, you guys were talking about what she does with new patients, and she had mentioned, you know, the cannabis, but also FODMAPs. And it's just interesting to me because I work with functional medical doctors and lots of diets are thrown around. That's not generally one. So I was just wondering why you would recommend that particular diet and if it has a certain relation to cannabis.
No, it just has a relation to irritable bowel syndrome. So those are the fruits and vegetables that are have sugars that produce a lot of gas and can contribute to the symptoms of irritable bowel. So it's a fairly standard approach in terms of a nutritional approach or dietary approach to irritable bowel syndrome and don't tell me, all I can tell you is the F stands for fermented, and then it's all of those saccharides and monosaccharides, all these sugars. And so there's some cruciferous vegetables that you have to be careful with, like Brussels sprouts and broccoli and cauliflower. You can have maybe one Brussels sprout, but two will send you over the edge. And so there are apps for it. And so it's about meal planning and trying to avoid some of those fruits and vegetables that might be gas producing and adding to the symptoms for the irritable bowel syndrome. But it's just for irritable bowel, not inflammatory bowel. Inflammatory bowel or other GI, I start looking at gluten, soy, dairy. I call them the hateful eight: tomatoes, grapefruits, shellfish, eggs, those are a lot of the foods that cause a low-grade IgG sensitivity, which can cause kind of a generalized inflammatory response in the body and can contribute to a lot of the chronic complaints, especially things like chronic fatigue and joint pain, migraines, and a lot of other symptoms that are not necessarily GI symptoms. But FODMAPs is for irritable bowel.
Okay, so it wasn't for general, it was just for that specific.
It was specifically for irritable bowel syndrome.
And even on the contrary, in general, a high FODMAP diet might be helpful for some people because we're really talking about the prebiotics that feed the bacteria in the intestine, and those good bacteria do need some nutrition. Well, thank you, everyone. We're over the line here. I just want to say that it just touches my heart so much that my mom is on and stays for the whole time. Again, that Ed, my super slow teacher, and there's all these clinicians on that are like people in the field that have been doing this as long or longer than me that I greatly respect, and people that I learn from, and all of you old faces and new faces. Thank goodness that we all get a chance to come together every month. It's really wonderful. Thank you all so much. And thank you, Patricia, for donating your time and expertise and company with us tonight. I so appreciate it.
Thank you, Dustin. I really appreciate your inviting me. This was a lot of fun. Thank you.
You're welcome. So, another reminder, we talked about Patients Out of Time before. Another great organization that Patricia and I are both a part of. We're both members of the board of directors of Society of Cannabis Clinicians. And so anyone that's in the medical field doing any kind of clinical work or research, you should check out our modest membership fees. It's another great organization like Healer. Thank you all. I look forward to seeing you next month. Have a safe, happy, and healthy month.